My name is Stephen Howell, and I'm a professor of mechanical engineering at UC Davis. And what I'd like to do now is share my past experience with mechanically aligned total knee arthroplasty from 1986 until January 2006, and then my more recent experience in the last 5 years with kinematic alignment, and share what I believe to be are the causes of dissatisfaction in mechanically aligned total knee. And I think it's primarily related to this goal of trying to achieve a 0-degree mechanical axis. In terms of conflicts of interest, I'm a co-founder of Otis Med, who makes the Otis knee, and a developer of the kinematic alignment technique for total knee arthroplasty. I'm a consultant for Stryker Orthopedics, and I'm a consultant and receive royalties from Biomet Sports Medicine for ACL products. In terms of an overview, I'm going to show you that the mechanically aligned total knee arthroplasty changes the obliquity and the level of the distal and posterior joint line from normal, which we believe is a cause of the dissatisfaction in 1 out of 5 patients that have total knee arthroplasty. And then we'll show you that this is due to aligning the components to the femoral head and ankle, and it's this alignment due to the varying shapes of the femur and tibia that changes the joint line in the coronal plane from normal and leads to kinematic malalignment of the knee. So let's look at our first point. The mechanically aligned total knee arthroplasty changes the obliquity of the joint line from normal. Let's look at the evidence we have from that, and then we'll show you that by doing so, we think this is what causes our dissatisfaction. I'd like to share with you some early results from an ongoing study where we looked at the paired alignment of 37 patients that had a kinematically aligned total knee arthroplasty in one knee and a mechanically aligned total knee arthroplasty in the other knee. And these patients received a rotationally controlled CT scanogram in which we were able to place the flange of the femoral component between the two femoral condyles to control rotation. And we measured the joint line obliquity, or the angle between the femoral component and the mechanical axis of the femur in both knees. And we measured the hip-knee ankle angle, or limb alignment, in both knees. And we measured the femoral tibial angle, or knee alignment, in both knees, which is the projection that one might see with a short standing radiograph of the knees. And the gold standard, if you will, was the joint line in the kinematically aligned knee, and we confirmed that it was restored probably within a degree or two of normal by measuring the thicknesses of the distal and posterior bone resections at the time of the total knee arthroplasty. And these thicknesses, when we corrected for wear and corrected for the kerf of the blade, should equal the thickness of the distal femoral condyle. And when that does so, then you've corrected the obliquity of the distal joint line back to that of the knee before the knee developed degenerative arthritis. So there's a big difference in the average joint line obliquity in the kinematically and mechanically aligned knee. And if we look at the parameter that we measured, which is a line from the center of the femoral head to the center of the knee, and then the angle that that line forms with the distal joint line, we find that the kinematically aligned knee is in about 2.5 degrees, if you will, more valgus than the mechanically aligned knee, which on average changes that joint line. And if we look at the difference within a subject, there's large differences ranging from 13 degrees in one direction to 5 degrees in the other, meaning that in many of our patients, we're really switching these joint lines away from what the normal alignment was, varying from 13 to 5 degrees. And what's of interest to the surgeon that really wants to strive for the so-called neutral or 0-degree mechanical axis, what we found is we actually get the same average limb alignment in the kinematically and mechanically aligned knee. And again, we're going to measure the hip knee ankle angle, as a measurement of limb alignment, and there's absolutely no difference between the kinematically aligned knee and the mechanically aligned knee, with a difference of less than 1 degree. There is more variability in the kinematically aligned limb, however. But what's of more interest is the large variability within a subject between the limb alignment. And so if you look at the difference between limbs in a patient, can vary from 7 degrees of varus to 7 degrees of valgus, for an overall difference of 14 degrees, which means that there's large differences in the alignment of the limb within a patient, yet overall you have the exact same hip-knee ankle angle as a group. Some surgeons like to look at the postoperative short radiograph of the knee to see if that might have a predictive value for wear and long-term function. And it turns out that it's the same average knee alignment as a group in the kinematically and mechanically aligned knee. So we're going to measure the angle formed by the distal shaft of the femur and the proximal shaft of the tibia in a short projection of the knee, and the kinematically and mechanically aligned knee are just exactly the same. The difference is 1/10 of a millimeter. The variability is exactly the same. But again, once again, there's large differences in knee alignment within a subject, which means that when you mechanically align the knee, sometimes it's going to be very similar to the kinematically assigned, but quite often it could differ from up to 8 degrees in one direction to 13 degrees in another direction, for a 21-degree range of difference within a subject. So if we think about long-term wear and function, on average the mechanical axis is the same, or the hip-knee ankle angle or the limb alignment is the same, and the knee alignment of the knee is the same. So the only thing different between kinematic and mechanically aligned knee is the obliquity of the joint line. And is this safe? And we think it is, because it replicates the normal knee. Indeed, it was the foundation of total joint arthroplasty as advocated by Hungerford and Krakow and Core, and they stated that an anatomic orientation of the coronal plane, wherein the joint line forms approximately a 2 to 3 degree varus angle relative to the mechanical axis, is desirable. Here you can see a projection of the normal joint line in 3D models recreated from CT scans. And here's an example of the kinematic and mechanically aligned knee. And there's the weight-bearing axis, and the joint line is in about 2 to 3 degrees of varus. That's the normal limb. And that's indeed what we're trying to restore with our kinematically aligned knee. And when you look at the mechanically aligned, it's actually turned in the opposite direction in this particular example. And remember that that variability can be almost 20 degrees within a subject. And so the mechanical alignment, when you change the obliquity, it does two things. It raises the level of the joint line as well as changes the obliquity of the joint line, and that will cause kinematic malalignment, where the axes of the total knee arthroplasty are not lined up with that of the original knee, and this leads to, in many cases, uncorrectable collateral ligament imbalance. Now, there's good evidence that the oblique joint line in total knee arthroplasty is associated with good long-term survivorship. In fact, 96% at 10 years. And if we look at Malcani's article from the Mayo Clinic published in 1995 of the total knee arthroplasty with the kinematic condylar prosthesis, the average position of the joint line in their study was 3 degrees of varus, and that was associated with a 96% of survivorship at 10 years. So if we compare our joint line alignment in our kinematic knee to that of this patient group from the Mayo Clinic, you can see that the 10-year follow-up study had the joint line in 0.5 degree of valgus, 1 to 3 of varus, 4 to 6 of varus, and greater than 7 degrees of varus, and you can see the percentages there. It's quite a wide distribution, if you will, and yet when you look at our kinematically aligned knee in that group I just showed you of 37 subjects, the majority of them are 1 to 3 degree varus, with a tighter and less variable group than the 10-year follow-up study. So this would suggest that the knee alignment, mechanical alignment of the limb, and the obliquity of the joint line in this study has good long-term survivorship, that there is excellent chance that kinematic alignment will have the same. So to conclude this section, let's summarize the alignment differences and similarities between the kinematically and mechanically aligned knee and paired subjects. There's no doubt that mechanical alignment changes the obliquity and the level of the joint line from normal, which tilts the femoral component in that plane away from the normal axes in the knee, which causes kinematic malalignment, and this is what we think is a cause of dissatisfaction in 1 of 5 subjects. And based on component limb and knee alignment, there really is no evidence to suggest that the mechanically aligned total knee should survive or wear better than a kinematically aligned total knee arthroplasty. So let's go to our next topic, which is try to show how this variable shape of the femur and the tibia exist, and therefore when you align the components to the femoral head and the ankle, that you in many cases are forced to change the joint line from normal, and that this kinematically malaligns the knee. First, let's acknowledge that the mechanical axis of the knee of the normal limb is not zero. It varies widely, and this is from Eckhoff's excellent work in JBJS in 2005, where they looked at the three-dimensional mechanics and kinematics and morphology of the knee in virtual reality. And they concluded that the mechanical axis is not a straight line through the center of the knee. And here you can see a normal limb, and the mechanical axis passes through the center, through just medial to the weight-bearing axis. And there you can see on the kinematically aligned knee, that same weight-bearing axis is restored. Here's another normal-looking knee, but it's valgus. This is the way this patient's been their whole life. And indeed, here's the kinematically aligned knee, which produces the limb alignment back to that which she's had for many years. And the degeneration in the left knee was caused by post-traumatic, and the right knee does not have these changes at all. Now, not only is most knees not a zero-degree mechanical axis, it rarely exists in normal limbs. And if we look at this table taken directly out of Eckhoff's article, 50% of the limbs normal limbs are in varus, 1% are in valgus, and only 2% of normal have a so-called straight line or zero-degree mechanical axis in which the line from the femoral head to the ankle passes through the center of the knee. So one of the reasons that the mechanical axis is not zero and the same in all individuals in the normal limb is because the shape of the femur varies widely between our patients. And we studied this when we looked at the longitudinal shapes of the tibia and femur in a group of patients and published in Core in 2009, and showed that the femur and tibia shapes are unrelated within an individual and are variable between individuals. And here is a projection of the distal fourth of the femur. And the anatomic axis is drawn down the center of the distal fourth of the femur. And if we remove the blackout, you can see that the anatomic axis in the knee on the left extends quite lateral to the center of the femoral head, where the one to the right goes right to the center of the femoral head. And this mechanical axis then is 9 degrees different from the anatomic axis in what we call a so-called varus femur, which is more common in the Asian or Pacific Rim population. And then in the valgus femur, it actually is 1 degree medial to it. So these wide differentiation in the shape of the bone can lead to malposition of our intermedullary and extramedullary guides. So here you can see the complications you can get into if you reference the IM canal or the center of the hip, because it will change the obliquity and the level of joint line depending on the shape of the femur. And here you can see the green line is a simulation of an IM rod, and if the IM rod is properly started and centered up the femur, then it's going to cut the joint line in too much varus and too proximal on the medial side and change the joint line obliquity and kinematically malalign the femoral component. And if we look at referencing the center of the femoral head, as you might do with a navigational system, again, typically in this particular case, the joint line will also be tilted and will be cut too proximally and in too much varus compared to the normal distal joint line, leading to kinematic malalignment. Now, just as the shape of the femur is variable between our subjects, so is the shape of the tibia. And here are the two examples of the extremes of the shapes of the distal of the tibia, and we've blocked out the distal 3/4 of the tibia, and we're going to draw an anatomic axis in orange from the center of the proximal tibia at the joint line through the center of the proximal fourth of the tibia and extend it to the ankle. And we remove the black out. You can see that on the one to the left that the anatomic axis passes quite medial to the center of the ankle joint, and on the run to the right it actually passes lateral to the center of the ankle joint. And so the mechanical axis is 6 degrees different from the anatomic axis in this so-called valgus tibia on the left, where the tibia takes a bow and goes laterally as it passes the distal fourth, and on the one to the right the tibia actually bows medial, and there's a 4-degree difference for a range in these two subjects of 10 degrees. So let's look at the consequence if you reference the center of the ankle, and we'll show you that it changes the obliquity and the level of the tibial joint line. So here you can see a projection of a right knee where the extramedullary guide is centered on the tibial cut that's already been made, and the alignment rod seems to be too medial to the ankle. And if we project it with the green line here on the radiograph, you can see that this patient has this so-called valgus tibia, and if you were to go ahead and use the extramedullary rod or reference it with nav, you'd end up cutting a more varus joint line. You'd end up being tight laterally and loose medial, and would force you to use a thicker piece of plastic and do a lateral release. And this is all generated by doing a non-kinematic cut on the tibia and by mechanically referencing the center of the ankle. Now, new evidence suggests that a 0-degree mechanical axis does not improve the survivorship at 15 years. And this is the very important paper by Perrett from the Mayo Clinic in 2010, which looked at the effect of postoperative mechanical alignment on the prediction of the 15-year survival of modern cemented total knee arthroplasties. And they showed that whether the knee was aligned within or outside the 3-degree window, it didn't make a difference in terms of the 15-year survivorship. And they thought that any attempt to describe alignment, whether it's aligned or malaligned based on this 3-degree window, is of little value in predicting the durability of a modern total knee arthroplasty. So in summary, mechanically aligned total knee arthroplasty, by referencing the femoral head and the ankle, because of the change and variability in the shape of the femur and tibia, changes the distal obliquity of the joint line from normal and causes a dissatisfaction in 1 out of 5 patients with mechanically aligned total knee arthroplasty. Aligning the components kinematically and not to the femoral head and ankle in our clinical experience is the key to improving patient satisfaction and stability and motion to the knee. And finally, based on the component limb and knee alignment in our paired study and Perrett's study showing that the mechanical alignment is not the key to long-term survivorship, we find that there's very little evidence to suggest that a mechanically aligned total knee arthroplasty should survive or wear better than a kinematically aligned total knee arthroplasty. And if you have additional questions or interest, please feel free to go to my website, and you can review surgical techniques and journal articles and presentations.